phospholipid syndrome, dermatomyositis, polymyositis, and Sjögren's, just to get a picture of some of the main antibodies that might come up in your UK LME MCQs. So we're first going to have a little look at systemic sclerosis. So this is an autoimmune condition which affects your connective tissues. It's characterized by increased fibrosis, and it often affects the skin and then some of your internal organs. The cause of it is unknown at present. They think it involves the activations of your fibroblasts, which then leads to excessive collagen production, which causes your skin manifestations of the condition. And then you also get angiopathy and blood vessel remodeling. So this can present with your telangiectasia. There is also an association between systemic sclerosis and other MSK rheumatological conditions, which are autoimmune, so things such as SLE, myositis, and Sjögren's. You can sometimes have a 20% overlap. What you'll find is once you have one autoimmune disorder, you're at more risk of further autoimmune disorders. So you often find that patients will also have other things going on alongside it. So there are two main types of SLE that you need to be aware of. The first one being limited cutaneous systemic sclerosis. So this one involves skin, which is often below the elbows and the knees. So this would be things like your hands and your feet and then your face. You're less likely to have internal organ involvement with limited cutaneous systemic sclerosis. The symptoms, you can remember it with the mnemonic CREST, because it used to be referred to as CREST syndrome. They've moved away from calling it CREST syndrome, but it's a good mnemonic for remembering some of the symptoms that you might see in patients. So that can be things like calcinosis, which is build-up of calcium under your skin, which you can see in that photo there. You can get Raynaud's, which is also shown in the image under the R. So it's where you get discoloration of the fingers due to poor circulation and blood supply. Often patients will present first with Raynaud's and then go on to develop the other symptoms. You get esophageal dysmobility, so this can present with symptoms of reflux, or if patients are having swallowing difficulties with both liquids and solids. You get sclerodactyl, which is the tightening of the skin, and you can see it on the hands here. And that is where you get a thickening, and that will be from your excess collagen production that we talked about before. And then you get telangiectasia, which would be your blood vessel abnormalities that you get with systemic sclerosis. Some patients will go on to develop pulmonary arterial hypertension, but it's less common in limited as compared to the other type of systemic sclerosis. But it's just something to be aware of, that it might come up in the question. So they might have all those symptoms and have some internal organ involvement. It's just less common with limited. The second type is diffuse cutaneous systemic sclerosis. So this is where your skin involvement is in your proximal limbs and your trunk. You have higher rates of internal organ involvement. So if there's internal organ involvement, it's more likely to be diffuse. Symptoms you can get the tight, dry or itching skin. So this can be in your proximal limbs, so closest to you, or your trunk. You can get Raynaud's as well, like you can get in limited. Patients might present with shortness of breath, and this can be as a result of lung fibrosis. You might get palpitations due to cardiac involvement, and you can also develop a sclerodermal renal crisis. So we can see this or identify this in patients if they've got a sudden rise in their blood pressure, or if they've got baseline hypertension and it's just getting slightly worse. That can be some of the first signs that they're having a sclerodermal renal crisis. So what is a sclerodermal renal crisis and what causes it? So there's lots of different theories, but from what the reading that I did around it, you get endothelial cell activation, which can lead to smooth muscle proliferation in the vessels, which leads to hypertrophy of the vessels, and then the blood is then at a higher rate and less of it is getting to the kidney, which can lead to ischemia. And then patients can present with an acute kidney injury, so they might have a rise in creatinine, rising urea on their blood test, and then they get severe hypertension because the kidney is trying to compensate for this lack of blood flow by increasing the blood pressure to see if it can increase blood to the kidney. When you're thinking about investigations, you're thinking, oh, I think this might be systemic sclerosis. What sort of investigations might you offer? Or if it's an OSCE, for example. So I always split it into bedside, bloods, and then imaging. So at the bedside, you can do blood pressure. So this can lead you to a diagnosis of a renal crisis. You can do an ECG to look at any heart involvement. So you might get some right ventricular hypertrophy, which you can see on an ECG if they've got pulmonary artery hypertension. Then urinalysis as well to look for renal involvement. So that can be things such as proteinuria or hematuria. Bloods wise, we do an FBC. Patients might be anemic, and then our user-needs will help guide ours on their renal function. And then we can send off some autoantibodies. So what autoantibodies are associated with systemic sclerosis? So you can widely do an anti-nuclear antibody, which will be positive in about 95% of patients, but it's not specific to systemic sclerosis. So just because they're anti-nuclear positive doesn't mean that you can say it's a diagnosis of that. You've got more specific antibodies. So these include anti-centromere. So these are more likely associated with limited cutaneous systemic sclerosis. And then you've got anti-scler70, which are more likely positive with your diffuse, so more likely to have internal organ involvement. I remember it as 70 is quite a high number and diffuse is it's more severe. So I remember 70 is with the more severe type, which is diffuse. And then there was also anti-RNA polymerase 3 antibodies, which is a new one from when I was revising. So these are more likely to be positive in patients who are associated with a rapid skin disease and a renal crisis, so with the more severe forms. But for your exams, I would just know that anti-centromere is limited and then anti-scler70 is for diffuse. Management-wise, there's no cure for systemic sclerosis. Treatment is focused on alleviating the symptoms that patients feel and then preventing any further deterioration in internal organ involvement or preventing it altogether. So some things that you can suggest for patients is education around Raynaud's, so avoiding certain triggers, so keeping your hands warm by using gloves or hand warmers, and then managing of an episode of Raynaud's, so teaching patients to slowly warm up their hands and feet, and they can do massages to increase circulation. Physiotherapy and OT have a role, especially if hands and legs are affected. We can give emollients for the skin, the dry skin that you see. And then we can use systemic agents to manage the skin disease and then internal organ involvement. So these would be things like methotrexate, cyclophosphamide, myclophenidate, and then biologics if those have not been effective. A thing to note with systemic sclerosis is that high dose or long courses of steroids can cause a renal crisis, so we need to use them in caution. So in a question, it is very unlikely that the answer will be steroids as a treatment for systemic sclerosis. So here's just a multiple choice question. It'd be really good if you guys could put the answer that you think it is in the chat. So a 57-year-old female has noticed that the skin on her hands has become very tight and that her fingers sometimes turn blue. She's also had difficulty swallowing both liquids and solids. What autoantibody is most associated with these symptoms? Do we think it's A, B, C, D, or E? So it's most likely going to be A. Yeah, you're correct. So A, anti-centromere. So if you look and break down the question, we can see that they're trying to get that she has sclerodactyly because the skin on her hands has become very tight and her fingers sometimes turn blue. So fingers turning blue makes you think Raynaud's. She's got sclerodactyly. She's having problems swallowing, so she's got esophageal dysmobility. So those would be leading us towards limited cutaneous. So, and the antibody associated with that is anti-centromere. So yeah, really good. Moving on, has anyone got any questions before we move on to SLE about systemic sclerosis that they want to ask in the chat? I take that as a no, so we'll move on. So SLE, systemic lupus erythematosus, is a condition. There's another autoimmune condition, which is multi-systemic, it affects multiple systems in the body. The cause of it is mostly unknown. It's thought to have both genetic and environmental factors that influence it. It's been found that carriers of the HLA-DR2 and DR3 are more susceptible to developing SLE. Also, environmental factors can include drugs. So drugs can cause certain drugs can trigger you to develop SLE. So these are procainamide, hydralazine, isoniazid, sulfasalazine, and carbamazepine. So those are really good drugs to remember to pick up in an MCQ as well. EBV infections can also trigger SLE. I feel like EBV infections can trigger a lot of autoimmune conditions, so it's a good one to remember. But basically, these environmental and these genetic factors all cause the body to have a reduced tolerance to its self-antigens. It no longer just accepts your antigens as being their own, and then it starts to attack them. So signs and symptoms. So SLE can affect so many of your systems. Most of the time, patients will present firstly with systemic symptoms. So these can be things like fatigue, fever, and weight loss. So they're quite vague, but you always need to have SLE on the mind when patients are presenting with things like that. You can get GI manifestations, so they might present with some mesenteric vasculitis, with pancreatitis. You get the malar rash, which is sometimes described as the butterfly rash, where it's an erythematous rash, which affects your nasal bridge and your cheeks, but it will not affect your nasolabial folds. You can get pulmonary manifestations, so the lungs, like pleuritis, pulmonary hypertension. Lupus nephritis is very common in patients, seen in 50 to 70%. And then they will present with things like hematuria, red blood cell casts in the urine, and proteinuria. Cardiac manifestations, so you can get pericarditis as a result of SLE, coronary artery disease. You can get MSA symptoms, so you can get an arthritis, an inflammatory arthritis associated with stiffness. And then hematological manifestations. So these are things like anemia, leukopenia, and thrombocytopenia as well. So it's a multi-system disease, and it's hard to predict which systems will be affected with patients. So investigations-wise, at the bedside, we could do urinalysis to look for lupus nephritis. So you'd be looking for things like hematuria and proteinuria. Bloods, we can look at the FBC, looking for things like anemia, leukopenia, and then thrombocytopenia. Patients will often have an elevated ESR and CRP because inflammation is high in the body as a result of the autoimmune condition. And then we can look for specific autoantibodies. So autoantibody-wise, first of all, you want to do a rule-out test. So you can do antinuclear antibodies because these are positive in about 95% of patients, but they're not specific to SLE. So if your ANA is positive, then we can look at some more specific antibodies. Your textbook one would be your anti-double-stranded DNA, which are 95% specific. And then you've also got anti-Smith antibodies, which are 99% specific. So first of all, you do anti-nuclear, because if that is negative, then it's very unlikely to be SLE. And then you do your more specific antibodies, such as anti-double-stranded DNA. Imaging-wise, you can do an MRI brain or an echocardiogram. So you might do an echo if you're looking for things like pericarditis or coronary artery disease. Management, so it would depend on how severe someone's presenting with SLE. So if they're presenting with mild disease, we can use things like hydroxychloroquine. We need to remember with hydroxychloroquine that it can cause retinopathy, so patients need to be cancelled on this and ensure that their eye health is checked up on regularly. Methotrexate is used. NSAIDs can be used in flares to help reduce pain if they've got like arthralgia. And then low doses of prednisolone and interarticular injections of steroids can be used. This is mostly if there's joint involvement, they'd use things like that. For moderate disease, so this is when maybe you're having more internal organ involvement, you can add in other immunosuppressants, so things like azathioprine, myclophenolate, and cyclosporine. So these are more aggressive forms of treatment. And then we can use some higher doses of prednisolone if necessary. And then for severe cases where you've got central nervous system involvement or they've got quite severe lupus nephritis, we can use high-dose steroids and then IV methylpred as well. And then that would be in combination with some immunosuppressants such as cyclophosphamide. If patients are treatment resistant, they might use biologics, but that would be guided by specialist rheumatologists as well. Well, all this treatment would be. But biologics would be the last line of treatment. So another question. So Tina is an 18-year-old woman who presents to her GP with myalgia and fatigue. So she's got muscle aches and she's really tired. She's got no other relevant past medical history. She did previously have a rash on her cheeks, which was treated with an antifungal cream, but it didn't really improve that much. On examination, her observations were normal. She's got no redness or swelling of her joints. She has got tenderness over her MCPs when you squeeze them, but her power is 5 out of 5 in all of her muscle groups. She's got a maternal aunt who was diagnosed with SLE. So she herself is concerned that she could have SLE. Which of the following blood tests, if negative, is useful to be a rule out test? So which of the following would you do? And then if it was negative, we would think it's not SLE. Is it A, CRP, B, antinuclear, C, ESR, D, anchor, and E, anti-centromere? If you pop it in the chat for me. Yeah, A and A. So yeah, it'd be anti-nuclear. So your CRP and your ESR aren't going to be much help. They might show that there's inflammation in the body, but they're not going to help us rule out SLE. Anchor, does anyone know what your anchor antibodies are most associated with? So it'd be vasculitis. So they help us diagnose vasculitis. And then E, anti-centromere, is something that we did earlier. So that would be your limited systemic sclerosis. So it wouldn't help us with ruling out SLE. And that's because we know that 99% of people with SLE will be ANA positive, and then we can go to our more specific antibodies after that. Has anyone got any questions about SLE before we move on? No? So moving on to antiphospholipid syndrome. So this is an acquired disorder which often predisposes patients to venous and arterial thrombosis. So they might have blood clots. They're common to have blood clots. They might have them in their legs or DVT, or they might present with pulmonary embolus. They'll have recurrent fetal loss, so patients that have suffered lots of miscarriages, and then they'll also have thrombocytopenia. So you can have antiphospholipid syndrome as a primary disorder, so they don't have any other conditions, or it can be secondary to other autoimmune conditions, and that is commonly associated with SLE. So around 30% of patients with SLE will also then go on to develop antiphospholipid syndrome. So the autoantibodies that you can do to correspond to diagnose it is anticardiolipin. You've got your anti-beta-2 glycoprotein, and then your lupus anticoagulant. I think the most important one to remember is your anti-cardiolipin antibodies with antiphospholipid syndrome. And when you're looking at questions like MCQ questions, look for details that they might have SLE in the background as well to help you decide, really, or help you be more confident with your choice. Other investigations is you could do a full blood count to look for thrombocytopenia, have a look at their platelets, and then do a coag, and then they'll often have a prolonged APTT. Management-wise for these patients is the management of their VTE risk, really. If they've not had a thrombotic event, they've not been diagnosed with a blood clot, we can just start them on preventative things such as a low-dose aspirin, 75 milligrams once daily. However, if they've presented, they've already got clots, it could be a DVT, a PE, then we need to start them on lifelong warfarin. And this would be with a target of an INR between 2 and 3. If they then develop a blood clot on this treatment, so they've been on warfarin, but then they re-present with a blood clot, then we need to consider changing their INR target to 3 and 4. We need their blood to be a bit thinner. And we can also add in low-dose aspirin at 75 milligrams once daily. If they're presented with an arterial thrombus, it would just be lifelong treatment with an INR target of 2 to 3. So I think the main things for antiphospholipid syndrome is to look out for recurrent miscarriages, lots of the VTE, and then have they got thrombocytopenia? Do they have a history of SLE, or is SLE run in the family? The fact that anticardiolipin antibodies are often positive in these patients, and the management would be managing their VTE risk. Have they had an event? or not. And then it's one of the only indications now for warfarin use. Does anyone know what the another indication would be for warfarin over a DOAC? It's not rheumatological. It'll be cardio. You can pop it in the chat. Yeah, mechanic heart valves. Very well done. Has anyone got any questions about antiphospholipid syndrome before we move on? No? Fab. So moving on to dermatomyositis. So this is an inflammatory disorder which often presents with symmetrical proximal muscle weakness. So in a question, it might be that the patient's suddenly struggling to get up from a chair. They're having to use their hands to push up from a chair, and then they might also present with skin features. So it's this proximal weakness in the muscle groups alongside skin features for dermatomyositis. Causes, it can be idiopathic, it doesn't really have a cause, just happens. It can be associated with other connective tissue disorders, like some that we've discussed earlier. And then one of the worrying things is also associated with underlying malignancy. So patients who are first presenting with dermatomyositis, we need to be also asking questions to rule out red flags for malignancy, most associated with ovarian, breast, and lung cancers. So presentation-wise for these patients, they might develop a heliotrope rash, which is often on the periorbital region, so around their eyes. They might have Raynaud's. They might also have a rash over their back and shoulders, which is very red. They're quite photosensitive, so the light will be hurting them. They might develop interstitial lung disease, so they might have developed shortness of breath and a cough. They might also get some dysphagia. We talked about the muscle weakness. They might also have tender muscles. It can also affect your respiratory muscles, so they might have respiratory muscle weakness, so really struggling to get those breaths in. And then you can get these characteristic Guthrun's papules, which are roughened red papules over your MCPs and your PIPs, and then you also get very dry and scaly skin, and it's often described as very itchy for these patients. So investigations wise, most patients will be anti-nuclear positive, so over 80%, so you can send those off. Around 30% of patients will be positive for some other types of antibodies. The one that I recognise is anti-Jo1. So if a patient has anti-Jo1, we'll be thinking dermatomyositis. You can also get antibodies to signal recognition particles, apparently, and then anti-My2 antibodies. But for me, it's knowing that anti-nuclear antibodies can be positive in these patients, and then more specifically would be anti-Jo1 for dermatomyositis with skin involvement. Just a note, you can also get polymyositis. So this is where you get the features of the muscle weakness and the muscle tenderness, but you don't get any of the skin manifestations. So you don't get the Guthrun's papules, a heliotrope rash, or anything like that. For polymyositis, you'll see an elevated creatinine kinase. In about 85 to 95% of patients, they'll have raised LDH, which is just a marker. It can be used as a marker in malignancy as well. And then their liver functions will be off, so the AST and the ALT may be raised. We can do an EMG for these patients to look at muscle electrical activities in the muscles, diagnosis with a muscle biopsy. So that's what the picture there is. So that's typical of polymyositis. And then they will also be positive for anti-Jo1 antibodies if there's lung involvement with these patients. So if they present with proximal muscle weakness and also difficulty in breathing, they might be positive for the anti-Jo1 antibodies. So if you've got anti-Jo1 in a question with skin manifestations, it's going to be dermatomyositis, and then if they don't have skin manifestations, the answer will be polymyositis. Management wise, it's high dose steroids, which are tapered when the symptoms improve. You can use azathioprine as well as a steroid sparing agent, because we have to remember that steroids, they are really good at what they do, but they have lots of side effects. They can cause patients to be insomnia, cause hyperglycemia, thinning of the skin. They're an immunosuppressant, so they have to be used cautiously. Has anyone got any questions about any of that? No. So just a question. So a 65-year-old woman presents with weakness of her thighs and shoulders, which leads to the difficulty climbing stairs and lifting objects. She's also noticed that she's got a purple coloured rash, which is most pronounced on her face and is on her eyelids. On examination, she has itchy and painful papules over her metacarpophalangeal joints. What antibody would most likely be positive in this patient? If you pop it in the chat for me. So if we break the question down, so she's got, anti-Jo1. So she's got weakness of her thighs and shoulders leading to difficulty climbing stairs. So that's your proximal limb weakness. She's also got that heliotrope purple rash, which is on her eyelids, which is a feature of dermatomyositis. She's then, on examination, you can see that she's got itchy and painful papules. So these are your Gottschalk's papules over her metacarpophalangeal joints. So it's leading you to the diagnosis of dermatomyositis, and then you need to know which antibody would be associated with that. So in this case, it's anti-Jo1. But if we just look at all the other antibodies that is given you, so anti-CCP is associated with rheumatoid arthritis along with rheumatoid factor. Your anti-Rho and your anti-LAR are associated with Sjögren's, and then your anti-Scler70 is your diffuse systemic sclerosis. So you can also, in these questions, work backwards. If you know what all the antibodies are, it can be a lot easier to answer the question. So I used to write like my notes in the question so that I'd look at the answers, annotate what I thought the antibody was for, then I'd read the question and see which one fit best. Any questions on dermatomyositis or anything? Also to note with dermatomyositis, there might be questions that are like, what would the next, so you've diagnosed it, what's the next relevant investigation? You just need to remember that it's common with underlying malignancy, so you might want to get a CT tap to look for a malignancy. So whether that be ovarian, lung. So if you do a thorax, abdomen, and pelvis, you'll be able to see any tumours. So moving on to Sjögren's. So Sjögren's is another connective tissue disorder. It's an autoimmune disease, again, which affects your exocrine glands. So your exocrine glands are secreting glands in your body. So these can be your salivary glands. So most often in Sjögren's, it affects your salivary glands, and that causes you to have dry mucous membranes. Sjögren's itself can be a primary disorder, so you can only have Sjögren's, or you can have it secondary to rheumatoid arthritis. If you've got it secondary to rheumatoid arthritis, it might present up to 10 years after your rheumatoid arthritis. So it's just something to be aware of. If a patient with rheumatoid arthritis then comes in with dry eyes, dry mouth, it could be Sjögren's secondary to their RA. So presentation-wise, you get dry eyes, dry mouth, you get vaginal dryness. You can also get arthralgia, so painful joints in Sjögren's as well. Raynaud's disease and recurrent episodes of parotiditis. So the parotid salivary gland can get infected due to the Sjögren's. The Sjögren's puts you at increased risk of infection. So patients that are repeatedly coming back with this issue, should we screen them for the other symptoms when we talk to them and then think about a possible diagnosis of Sjögren's? So with Sjögren's, investigations-wise, if it's primary Sjögren's, we think that that's the only thing that's going on. We can look for autoantibodies such as anti-Rho and anti-LAR. Anti-Rho is more commonly positive in patients, but you also get anti-LAR in about 30% of patients. So just knowing that Rho and LAR are positive. They can also be called SSA and SSB as well. So just being aware that's in a question that they're thinking Sjögren's. If it's secondary Sjögren's, they might also be positive for rheumatoid factor as well as antinuclear antibodies. Test-wise, we can do a Schirmer's test, which is a bit of filter paper that you put near your conjunctival sac, and then you just measure tear formation. And then with Sjögren's, these patients will have a reduced tear formation because they've got dry eyes. So that's a very crude way of doing an investigation to support your diagnosis, but mostly it's through antibodies. So management-wise, it's just replacing these the exocrine function of your gland, so you can give artificial saliva and tears. You can use pilocarpine orally to help stimulate saliva production, so that works by stimulating your muscarinic receptors, and then this causes your parasympathetic nerves to promote salivary and lacrimal gland secretion, so just to try and increase your body's production of saliva and tears. You can also offer patients vaginal lubricants, and then hydroxychloroquine can be considered if they've got joint involvement, so to help with joint pain. Has anyone got any questions about any of this? No? So finally, we've got a 58-year-old lady now. She presents with a 3-month history of dry eyes, dry mouth. She's got some joint pain and she's quite tired. On examination, you can see that she's got conjunctival injection. She's got a decreased salivary pool. I don't actually know how you'd see that on examination, but you could notice that she's got dry mucous membranes and she's got lots of mouth ulcers. She also has a positive Schirmer's test. So what would be the most appropriate antibody to test for from the options below? If you guys put it in the chat. So we know that anti-CCP antibodies are for rheumatoid arthritis. Do we think that this presentation fits with rheumatoid arthritis? Yep. Yeah, D is correct, so no. And then ANCA antibodies, like I said earlier, are to do with vasculitises, and this description of her presentation doesn't fit with that. Anti-Jo1 would be thinking dermatomyositis or polymyositis, but she's got no muscle weakness and she's got no skin involvement really. And then your anti-Ro and anti-La are Schrogens. So she has got dry eyes, dry mouth, so that is most likely going to be Schrogens. And then your fifth option is anti-double-stranded DNA antibodies, which is associated with SLE. This doesn't really fit with SLE. You have got arthralgia and fatigue, but you're less likely to have the oral ulcerations, the dry eyes and the dry mouth. So it's most likely going to be Schrogens. So we need to do anti-Ro and anti-La. So I just wrote those down there. So they're just my references. Has anyone got any questions about any of the content we covered? I do appreciate that it was very quick. But I just like, my advice for learning is just learn which antibody is associated with which condition, and then once you know that, you can work backwards in your MCQs, and that will really help you approach the question. Because the worst thing that can happen, oh yeah, I can. There you go. The worst thing can happen is you see the answers and you don't know what the answers are. So then you're like, how am I going to answer the question if I don't actually know what those antibodies are for? So yeah, if you guys just provide feedback and then you'll get a certificate for attending. I hope it was helpful. No problem.